tardes. Muy buenas tardes a todos. Good afternoon. My name is Erika Caballero. I am a member board for the Región 6, América Latina. I moderate this session. This session is Global Perspective and Advanced Practice Nursing. Have two excellent speakers, Melanie and Consuelo Cerón. Advancing practice roles for nurses have been evolving globally for over 50 years in response to the patient need, lack of adequate healthcare provision, and shortfall of medical doctors in some areas. They have a significant impact on global healthcare, addressing to until nation sustainable development, and global healthcare addressing to the United Nations sustainable and universal health coverage. There is a large body of literature calling of clarity of advanced practice role. In the International Council of Nurse and ICN Nurse Practitioner Advanced Practice Nurse Network have developed definition on guidance of developing advanced practice roles, which has receiving and update this definition. This work is essential, especially for countries where the role is new or not implemented. This presentation provides an overview of advanced practice nursing included, the barrier and challenges to developing this role. It will present the update ICN definition and would finish with the case study illustrating the success of developing advanced practice nurse role in Chile through collaborating working. The first speaker is Dr. Melanie Rogers. Dr. Rogers is a University Teaching Fellow of Advanced Practice Nursing in the University of Huddersfield in UK and Chair of International Council in Nursing and the Nursing Practitioner Advanced Practice Nursing Network. She holds the title of Queen Nurse and was 30 years experience in acute medicine, endocrinology, gynecology, oncology, and emergency care in UK and Canada. Dr. Rogers is passionate about advanced practice as a way providing the care patient need when and where they need it. Her presentation will provide an overview of global perspective of advanced practice nursing, including the new ICN definition for advanced practice nursing roles.
So good afternoon, bonjour, buenos dias, ni hao. I'm absolutely delighted and honored to be invited to speak to you about the area that I'm very passionate about, advanced practice. I am absolutely amazed at the conference and speaking to so many amazing nurses about your stories. And the Singapore Nursing Association have done an incredible job. So huge thanks to them and to the ICN. So, advanced practice nursing. I thought I could put lots of slides up with definitions and discussion, but it's day 3. And for me, the most important part of our work is the patients that we care for. So I'm going to start with some illustrations of some stories of advanced practice. I'm going to talk a little bit about the definitions, and I'm going to hand over to my friend Consuelo from Chile to talk about how they've implemented advanced practice. So first of all, just want to get an idea about how much you know about advanced practice and how much it's prevalent in your country. So I'm going to do a show of hands, And the first question is, coming soon, does your country have advanced practice nurses? Can I just get a show of hands? So about 3/4. Great. Does your country have nurse practitioners? So that's a little less, about half. Those who have advanced practice nurses or nurse practitioners, is the title protected, and are they at master's level or master's degree? We're going down about 1/4. Now, I'm hoping the next question may have every single hand up, because I want to ask, do you think advanced practice nurses positively impact healthcare? Yeah. So that was a better one to end on. So I absolutely think that advanced practice nurses impact healthcare. And this is me. So I'm an educator, I'm a researcher, I'm the Queen's nurse. That doesn't mean to say that the Queen phones me and asks me for healthcare advice. It's a recognition of my work for advanced practice that's bestowed from the Queen of the UK, which is amazing. But this is my most important part of my work. This is the work that I do with my patients. So I work in primary healthcare, and we've already heard about a number of the global issues in primary healthcare, mental health, non-communicable diseases. This is what I do day to day. And I wanted to just talk a little bit about the difference I make to my patients, to the health service in general, to the disease burden, and to the country. So all of us know that there are many issues in developing countries in terms of primary health care. It is a major issue in developed countries. So in my practice, in a GP surgery, family practice, it takes 3 to 4 weeks for a patient to get an appointment. And that is absolutely unacceptable. Patients should be able to get the care when they need it. So just bear that in mind when I talk a little bit about my practice and why I work in the way that I do. So 3 to 4 weeks to get seen. And I don't agree with this, but I only have 10 minutes per patient to build a relationship, to make an assessment, to diagnose, to treat, and to manage. And some of those areas have historically been in the medical domain. But I'm a nurse, and my heart is nursing, and what I want to do is bring those skills to my nursing portfolio to offer the patient the best possible care that I can, and to provide the care that they need holistically. So that's a real big ask when you have 10 minutes. So the first thing that I do, and some of my medical colleagues laugh at me because they have an automated system where they can say, press a button and it calls a patient in. The first thing I do is go into the waiting area to greet my patient and walk in with them so I can begin to build a relationship. I have my computer. A lot of my colleagues sit at the computer making notes. I turn away so I can look at my patient and ask them how I can help them. I don't start bombarding them with a lot of the questions that are historically taught in medical training. So I want to build that holistic relationship where I have a rapport, where my nursing skills are the paramount skills for that relationship. And then I'm going to use some of the medical skills to offer a package of care that the patient needs. So the patient I want to talk about, she's called Jane, and she comes from South Africa. It has taken her 4 weeks to get an appointment to see me, and she has 10 minutes to tell me what's wrong. So it was a little bit obvious. She kind of walked in like this. So any of us as nurses would pick up she maybe has a problem with her limbs. So she talked to me. She works in a school. She has a foot problem that is causing her major problem. She's unable to work properly. So I took a history. I examined her, and I made a diagnosis and talked to her about management. Now, in my practice, that is all that my colleagues want me to do. They want me to treat the presenting problem and then say bye-bye and call the next patient in. When I was talking to Jane, I looked at her face and noticed a lesion. And I asked her about the lesion, and I knew she came from South Africa. She had a lot of sun damage. And she said, yes, it's been growing over the last 6 months. And I knew that there were signs of a cancer. So I was able to assess that, diagnose, and refer. And again, you could say, great, I picked up a cancer that's going to get early treatment. Let's say goodbye and get the next patient in. But I also noticed we have an electronic record. She lives with her mother. Her mother had recently been admitted to hospital. And this is all within 10 minutes. So I'm not speaking at 100 miles an hour. I'm trying to give her time. And I just said, I understand your mom's been in hospital. How are things going? At which point she broke down. She told me that she'd cared for her husband for 20 years with a neurological condition. And over the last 2 to 3 years, he had been exceptionally disabled, and she was the main carer while trying to work and bring her children up. After he died, her mother said, I want to come from South Africa and live with you. And Jane thought, it's been a really difficult time, but of course I want my mom to come and live with me. So her mom came to the UK and said to Jane, I'm only going to stay with you to 2 to 3 months, and then I'm going to get a sheltered accommodation, so support at home. After a year, her mom still hadn't gone. Her mom said, I'm enjoying living with you too much. At this point, Jane had lost her husband. She had hardly any social interaction apart from work. She felt obliged that her mum stay with her, even though it meant that she was now becoming depressed and anxious. And we were able to talk about the fact that her mum was now in hospital. Maybe we could make a plan to help her mum move into supported living and look at some of the factors that might improve her mental health. So within that consultation, I would say to my patient, I picked up a cancer, I dealt with the issues she came about, but I also went deeper, as we do as nurses, to look at the psychosocial, the spiritual elements. What would it be that would give her hope? And to me, that encompasses what we do as nurses, what we do as advanced practice nursing. And it is nursing through and through to the heart and how we bring that together. The other case I want to talk briefly about is Shona. So Shona is a nurse practitioner. She's working in the north of Australia, and she works with Indigenous communities. This area is exceptionally hard to reach. The nearest hospital is 600 kilometers. The patients there had not had any consistent health care. They had medical provision intermittently, where people would fly in for a few months and leave. The patient that came to see Shona was 53. She looked 70. She looked exhausted. She said to Shona, I have had a problem for 7 years. It's women's issues. Shona asked her about it, examined her, found a massive uterine prolapse that was ulcerated, smelling, causing her pain and discomfort. She said, why didn't you come sooner? And the lady said, the medics who came were male. I didn't know them. They didn't come back. They only came from week to week. I didn't feel comfortable. You have come and lived with our community for the past year. I trust you. Shona sent her to a hospital. She had surgery. 2 months later, this lady came back, looking alive. She said, I'm no longer incontinent. I no longer smell. My grandchildren want to play with me. Her life was changed. And Shona said, this is why I do what I do. And this is the stories that we should be telling. Every single one of you in this room has stories. And sometimes we look at leaders and think, well, they're the ones who can speak and to influence policy. By your story, you can influence policy. So make sure that your stories are heard. So this is our health quest, to improve patient care, to improve access, to improve health outcomes. And we want our patients to have the best experience we can. And we will meet the global health challenges as we do this. Health, as we know, is a human right for all. And we need to make sure that we ensure universal health coverage happens. And as we were mandated a couple of days ago, we need to stand up and make sure that we do this as nurses. So APNs, we are massively important in terms of meeting the global challenges. This is a leadership role. It's about bringing together innovative approaches to healthcare. So for Shona, she was able to revolutionize that lady's life. I was able to assess the mental health, prevent a cancer, and deal with the non-communicable disease the patient presented with. This is not a medical substitution role. This is not task shifting. It is needed because we have a medical shortage, but nurses are in the right place to do this because we bring together the best of nursing with the best of medicine. But this is a nursing role about the advancement of nursing and something that we should be very, very proud of. We're focusing, thank you. Yeah, I'll just do the definition. We're focusing on holistic care. We're focusing on care across the continuum. I'm running out of time, so I just want to say to you there is a massive issue in terms of definitions. In 2010, Joyce Pulcini found 14 different titles used for advanced practice. More worrying, in 2017 in London, Alison Leary found 595 titles used for advanced practice, and many of the people using those titles weren't nursing. So we need to protect the title, and our new definitions are hoping to bring clarity, because some people felt the ICN definition for advanced practice wasn't clear. So we're now saying APN is the overarching title. It must be a master's degree, not just master's level. And that there are two roles. Clinical nurse specialist is the specialist role. Nurse practitioner is the generalized role. And they will both be under that umbrella. We're producing guidelines which will talk about the characteristics and assumptions. It's 40 pages long, it goes into real minutiae, and it's been approved by our advanced practice organizations. It's with the NNAs now, and will be launched in a month. So look out for it, and come and talk to me if you'd like to know more. I'm going to hand over to my colleague, but again, just want to reiterate, this is about values-based care, this is about holistic care, and this is about being the best we can as a nurse. Sorry.
Thanks, Dr. Rogers, for enlightening us the definition and principal point to be considered. The second speaker has Magister Consuelo Cerón MacKay. Started his professional career as bedside nursing in an intensive care unit in a pediatric hospital. For 5 years, MacKay served as director of the School of Nursing, and since 2015 has been dean to the Faculty of Nursing and Midwifery in Chile. She is an active participant in the Chilean Association of Nursing Education and in the technical group developing competence of advanced practice nursing in Latin America countries. She also senior research fellow of the Center of Health Outcome and Policy Research from the University of Pennsylvania, and leading the research team for Project 2 RN4CAST in Chile.
I think it's the same. Thank you very much for the invitation to participate in the ICN Congress. I'm honored to be part of it and want to share with you the Chilean experience into developing the APN role. Well, APN role in countries like the United States, Canada, and many others have proven to be a strategy to drive primary health care in a highly cost-effective, safe, and quality way. In those countries, nursing has developed over 50 years to train APN, expanding their scope of practice and generating evidence to demonstrate the quality of their practice. while in countries like Latin America and the Caribbean, the APN is a relatively new concept. In Latin American countries, many nurses with a bachelor's degrees work beyond their scope of practice as an APN in response to the population's health needs, but without the formal education and regulation. Thus, and encouragement from Pan American Health Organization motivate us to implement the APN role in Chile following the PEPA framework. Sorry. Great. Well, let me introduce my country. Chile is located in South America. It is a long and narrow country. In fact, if Chile is located on the map of Europe, it ranges from Egypt to Scotland. We were a Spanish colony, and during our short history as an independent country, only 200 years, we have received European immigration from countries like England, Germany, Italy, and Croatia. And these last decades, immigration came from Latin American countries like Peru, Colombia, Haiti, and Venezuela. Actually, we are 18 million people, and more than our 60% of the population are immigrants. We are a developing country divided in 15 regions with a great variability in the gross domestic product, climate, and density among regions. The Chilean health issue, well, the life expectancy in my country is 79 years old with a quick population aging that lead an increase of chronic condition. In fact, Chile ranks 6th among the OECD countries with the highest proportion of adults with diabetes, reaching the 10%. Also, the 54% of the population is overweight. Our Chilean health system is a tale of two systems. The public sector, financed by the Chilean state, and cover almost the 80% of the population, and the private system, financed by the private insurance that cover the rest of the population. In order to implement the APN role, we follow the PEPA framework. The PEPA framework is recommended by the international literature and utilizes successfully in more than 16 countries. It is a systematic strategy to guide countries through the implementation process. This framework provides a guide to address known barriers to the effective design, implementation, and evaluation of APN roles. Its adaptation to the local context allows a solid planning based on the information and relevant data of the population and health system of each country. This framework includes 9 steps in a flexible and iterative process. The Chilean experience has reached until the step number 7, since during this year, 3 universities have developed an APN master program with a national consensus about the role definition based on the ICN definition, competences, and the scope of practice. So let's go to the step number 1. In defining patient population and describing current model of care, we can highlight adult population with chronic disease. The APN could integrate nursing and medical care with greater emphasis on health promotion and disease prevention activities, foster increased patient involvement in their care and treatment adherence, increase access to care and improve chronic disease management, and physicians could better focus on patients with more complex health issues or problems. In the step number 2, we identify stakeholders and recruit participants. At international level, we identify Pan American Health Organization as the main supporter. Pan American Health Organization has promoted the APN implementation for Latin American countries in cooperation with the collaborating centers, organizing webinars and 2 very important summits for it. One was held in McMaster in 2015, and the other was held in Michigan in 2016. Moreover, we as a country have been receiving support from international support, from School of Nursing, from University of McMaster, George Washington University, the School of Nursing of Boston College, and the School of Nursing and Health Science from University of Miami. At national level, in 2016, we held a summit in Santiago, gathering authorities from the Ministry of Health, primary healthcare workers, Nurses Association, and academics from nursing school across Chile. This summit were replicated in the north and in the south of Chile. As a result, we organized an APN network for primary health care. We also generate a report with the main agreements about how we can go forward in order to implement APN role in primary health care. We have also sent letters to the press, held meetings with authorities of the Ministry of Health, Association of Physicians, nurses, among others. We have also been invited to participate in different conferences about to present the APN role. For example, we had a good acceptance in the Congress from Association of Medicine Faculties from Chile. As well, the APN, it has become a relevant topic in seminars held by scientific nurses societies. For example, the Nurse Society of Intensive Care, the Nurse Society of Oncology and Nephrology. At the academic level, we have published papers in important national journals. Well, for determining the unmet patient health needs, according to the information raised mainly in the summits, in these summits and also in the meeting, we find two views on which population with unsolved health needs APN could focus. First of all, according to the view of primary healthcare workers, mainly I can highlight the relevant on patients with chronic condition with a high prevalence among the population, diabetes and hypertension. And according to the Ministry of Health views, also there are coincidence because the priorities are chronic disease, diabetes and hypertension, elderly people, oncology, and mental health problems. During 2018, we were invited to collaborate with the working team related to human research in the National Cancer Plan 2018-2028, together with other three important nursing schools in Chile. As a result of this work, the National Cancer Plan includes the APN role in cancer health teams and considered to grant a more active role to nurses in the diagnosis, treatment, and follow-up patients with cancer. In the implementation strategy, well, some strategies have been planned following PEPA framework and international recommendation, but others have developed or have been developed in response to the opportunities that have risen. For example, the intervention in the National Cancer Plan. But we can highlight among them the Santiago Summit, where we brought together primary healthcare stakeholders to discuss the concept and role of the APN, the confirmation of the Chilean APN primary healthcare network, which has led and joined in a single coalition the academic world, the Cancer National Plan with collaboration with the Ministry of Health, and the confirmation of an expert team with faculties from 3 different schools of nurses and clinical nurses to develop the APN in oncology. In the future, we identify the need to achieve joint work between the Ministry of Health, city councils, the National Nurses Association, and the Chilean APN PHC network to implement a pilot project to address patients with chronic conditions in primary health care. Well, there is a missed slide, but I just wanted to let you know that for the implementation of APN in oncology, we have established an expert teamwork in oncology with different backgrounds. Some nurses from this expert teamwork belong to the academic world. Some are for the clinical settings with a relevant experience in oncology, and one of our members, strategically, is a nurse and a lawyer at the same time. We have made an important advance in the step number 7, such get a consensus about the APN role definition, competence, and scope of practice. One school of nursing has 7 students in the APN oncology program, Another 2 schools of nurses will launch the program soon. And we have a draft paper related to APN legal aspect in Chile that hope will be submitted by the end of the year. Also, we would like to start to work on protocols and guidelines to support the APN role while we wait the legal framework for advanced role, since it's a long way to get it. The final thoughts, PEPA framework has been useful in recognizing opportunities, stakeholders, and to work aligned with PAHO, recognize barriers, and also has been useful to pay attention to regulation. The establishment of the Chilean APN primary healthcare network and the expert team work in oncology has enabled joint work and unification of the APN role definition, competences, and the scope of practice. We found no big resistance about the APN role at authority level or physician association, but there is a need to collaborate more closely with nurses association. There is a national consensus about the needs to advance in universal health coverage. Thank you very much.
I want to thank to Magister Cerón for showing us how to make advanced nursing in practice in Chile. For the time, don't have a question, but please give a big applause for the excellent speaker, please.
If you want to know more, there's a policy cafe at 1 o'clock tomorrow on advanced practice.
So, good afternoon, dear colleagues. I'm well aware of the time, but I'm really delighted to be here with you, esteemed floor, in front of this prestigious floor and these prestigious guests. I'm honored here to present the ICN leadership programs. My name is Alessandro Stievano, and I'm working as an Associate Director for the International Council of Nursing as a Director for Nursing and Health Policy. In this session, we will have the presentation of our 2 programs on leadership, the GNLI program, Global Nurse Leadership Institute, and the Leadership for Change program. But before starting, I would like to acknowledge Diana Mason was supposed to be here with me because we drafted together, sketched down together the program of this event, but she couldn't attend, unfortunately, this event for health problems. And I really would like to give her a great applause. Thank you so much, Diana. Before starting with the GNLI program and to give the word to Jane Salvage, who is the global leader for the GNLI program, I would like also to acknowledge the management team at the ICN who worked very hard to organize this program and also the events around the world. And their names are Claire Med and Tanya Pavlovich. Thank you so very much. So without further ado, I don't want to be too long with presentation because I'm very well aware of the time. So I would like to give the word to Jane Salvage, who is our global leader for Global Nursing Leadership Institute, and she will present herself a little bit because, as you probably know, we don't have so much time. Thank you so much.
Good afternoon, everyone. One sentence about me. I'm from the United Kingdom. I, at one time, was the European chief nurse in the World Health Organization and also worked at headquarters. I've done lots of work in different countries. I was the editor of Nursing Times magazine, but one of the most exciting times in my professional life has been more recently, for the past 4 years, as the program director for the Global Nursing Leadership Institute. So I want to just tell you a bit more about that. We all know that nursing needs to be at the top table in every health-related organization, the table where the big decisions are made. This table might be in the boardroom at WHO, or in national, regional, and local governments, or in health service provider organizations, in education, in NGOs, and many more. ICN and our associations have been fighting for this representation for many years, and we still have a long way to go. And even when nurses do have a seat at the top table, they often have little impact. They may be the only woman in an all-male environment. They may come from a culture where women are expected to be silent and submissive. They may be ignored by colleagues who do not understand the true scope and impact of nursing. And many of these top nurses have never had the opportunity to develop the competencies they need to be effective in these challenging environments. And the answer, of course, part of the answer, is provided by the Global Nursing Leadership Institute. We prepare top nurses from around the world to drive policy that improves the health of people, improves healthcare, and advances the nursing profession. With me so far? Yeah? Good. So we're a strategic leadership program for nurse leaders who think globally and act locally. You can see here the structure of the annual program. It's evidence-based and it's highly interactive. It's developmental. It's not academic lectures. We create a learning community that helps people to learn how to connect, to trust, and to share, which are essential leadership skills. This year, we're focusing on 3 topical themes related to the Sustainable Development Goals. This is global thinking, and it can feel overwhelming. To bring it home locally, all our participants do a practical project in their own workplace or network relevant to the SDGs. Sorry?
Your slides are not projecting.
Oh. Interesting.
Yeah, now it's full. Before it wasn't.
Okay. I love technology, don't you? It's much easier just to stand here and talk without the slides, but anyway. So just telling you a bit about the program. The focus is clearly on policy leadership. Nurses at all levels, from ward to board to international stage, need to be much more savvy about politics and policy. This means looking outside the nursing box. It means avoiding nursey talk and the virtue script. It means framing our messages and proposals in language that appeals to politicians, policymakers, the media, and the public, and telling them compelling stories that highlight the solutions we offer. Okay, we're keeping up here. So you can see here where our participants, the kind of work that they do. And since 2009, we've welcomed nearly 300 participants from around 80 countries. We have powerful alumni networks with deep and lasting connections. So you can see all these different kind of leadership roles. What they all have in common is their roles where they influence policy on nursing and health. The program is very challenging for them and for Diana Mason and me as the current facilitators. People bring widely different languages, experiences, personalities, backgrounds, cultures, beliefs, and ways of working. It isn't always a comfortable ride, but that's part of the magic. We stretch ourselves to learn from each other and explore what diversity really means. We emerge as enriched and more rounded people, and we're more effective leaders. And it is really one of the most thrilling experiences I've had in my extremely long professional life. I know I don't look it, but. So here is one of our groups. This is from 2018, and it's lovely to see that there are a number of people from this group here today. And of course, they are wonderful. And you would expect me to say it's wonderful, but we have objective evaluation every year by the scholars, by the faculty, and by the donors. And the results are outstandingly positive. These are just some of the things that they have told us about what they gain from the program. Our alumni use these skills in many activities to improve health outcomes and ensure there is nursing in all policies. These include leading and contributing to national action plans for nursing and other major policies, reforming nursing education, leading clinical developments, working in public health, conducting research, and ensuring that nursing voices are heard alongside other stakeholders. They're also in the forefront of the Nursing Now campaign. So I want to close, my time is short, by saying what of the future? Well, we have 23 million nurses worldwide, but very few have access to effective developmental strategic leadership programs, especially people from lower income countries. So we need a GNLI that can develop not just 30 a year or even 300 leaders a year. We need development for 3,000 or even 30,000 nurse leaders a year. We need a GNLI in every region of the world. And as ICN announced this week, we're launching a Daughter of GNLI program so that we can extend the program in different countries and across different networks as our contribution to the Nightingale Challenge. So I do hope every one of you will think about whether you want to make this program possible, and we can work with you to make that happen in your network or your country. Our main sponsors are the Burdett Trust for Nursing, United Kingdom. They're very supportive and generous, but we need to tap into new sources. We need to persuade the big funders that investing in strategic nursing leadership brings excellent returns for global health. And above all, we need to persuade them, nurses don't just make tea, they also make policy. So anyway, I've told you how great the program is, but you're going to hear about it from two of our wonderful alumni who will tell you their own experience of it. First of all, Michelle and then Jed. So they will introduce themselves. Over to you.
Thank you, Jane. My name is Michelle Gunn. I'm a Director of Nursing for Queensland, Australia. I've got qualifications in both nursing and law, so that sort of gives me an interesting sort of professional perspective on a lot of our issues. I was a scholar in 2017, and the program is an incredibly amazing program. I'd like to start by saying that I would like to thank the ICN and also the Burdett Foundation for their support, for their vision of nursing, and for making such opportunities available to nurses around the world. This photo here is of the group from 2017, and as Jane actually said, we are an incredibly diverse group. We come from many cultures, many backgrounds, we have so many differences, and yet there is so much that unites us. We are, and every group each year is a celebration of diversity, united by a love of nursing and a hope for a world where people will have better health and well-being. On the first day of the program, we were asked why we had come to do this particular course, and I tend to like to write things down, so I wrote down what my colleagues actually said. They said, nursing is a universal language. Nursing is a political act. I won't go through all of these because we've got quite a bit of, we haven't got a lot of time today, but the one that really stood out for me on the day was my colleague who said that they came to find a friend to help them. And I can assure you that that particular friend who is actually here with us at this conference today not only found a friend to help them, but found 27 friends to help them. In terms of personal growth, and I say personal, but personal and professional growth, I came to recognise the increasingly global nature of healthcare, the importance of being politically astute, the importance of education, and the importance or essential nature of collaboration and partnerships, and of course the need for effective leadership. Not just leadership, but leadership that's actually effective. I became really aware of my own inherent capability and capacity. And I started to realise, and I'm just going to quote Liam Neeson from the movie Taken, I have a very particular set of skills. Now, I also have a responsibility to use them wisely, and I won't be using them in exactly the same way that Liam used his skills. I'll use them to ensure that we actually do pursue good health and well-being. The GLNPI program was, as Jane said, a remarkable experience. And from that experience, it has really had a transformative effect on the way in which I go about my business as a nurse. It's changed the way I work locally, and I am in the same role that I was in, but I do it in a different way, and I love the role that I'm in. I do a lot of work around legislation, and where once I may have only considered issues and matters that were close to me, I now consider how this issue plays out not only at a local level but at a national and an international level, and I learn from the experiences of others so that I can actually come up with a solution that is the very best for my community, but also takes into account how it will impact on other communities and right around the world. Because of time, I'm going to move on a little bit, but I am more involved nationally, and I'm putting my hand up to do what I can internationally as I am today. Since coming home from the GLI, I have actually also led a network of nurses. So we've stayed together through the use of some very simple technology, Zoom, messaging services and so forth, and lots of emails. We meet regularly, sometimes face-to-face where we can, and other times via technology, to continue to support each other, to learn from each other, and progress policy issues where we think they need to be. This is a poster. I realise you can't read it, but this is a poster where we actually talked about our experiences of GLNI and all the things that we had done since then. We prepared this for the launch of the Nursing Now campaign, and we were proud to know that Lord Nigel Crisp actually mentioned us in his opening speech. While time really doesn't permit for me to say very much more, I would really like to say that we are stepping up to the policy table. At times we are inviting ourselves, taking our own chairs, but also opening the door and letting other colleagues in and making sure that there's a seat at the table for them. I really recommend this course. It is the most remarkable course that I have ever done, and I'm sure you would find it to be equally so. Thank you very much for your time today.
Kia ora everyone, and good afternoon. I'm Jed Montare. I am a senior lecturer from Auckland University of Technology. Now, from Auckland, New Zealand. First, I would just like to acknowledge that I am very grateful to be standing here today sharing my learning experience from the GNLI program. In my early career as a nurse, academic, and researcher, this is my first time to stand in a crowd as big as this, and I'm convinced that this confidence is from my exposure to GNLI. So my learning experiences, first thing is communicating the right message. For nurses to effectively lead and influence policy, we need to communicate the right message to policymakers. I initially thought that is an easy thing to do. Being a millennial myself, I thought you just have to say what you need to say. However, it is not as simple as that. Choosing the right message goes beyond word choices, keeping in mind some important considerations such as who do you represent with the message you are giving? Whose interests are being served? And how can it benefit not just the profession but the wider communities? Obviously, it is also about doing your homework and being ready to answer tough and expected questions on topics we don't often talk about as nurses, things around budget implications, economics, and business delivery models. The second important thing that I've learned is being confident in influencing policy. Nurses should stop thinking that we have less or have nothing to contribute. We should be proactive. And one of the take-home messages from the program, and you might have heard this already, is if you don't have a seat at the table, then bring your own chair. How did I apply all this learning? After GNLI, I've been appointed on national leadership roles. I'm currently the chair of the NCDNO Nursing Research Section, a national committee promoting nursing research among New Zealand nurses. It is a leadership role that requires engagement in policies that progress evidence-based practice through research, creating submissions, and responding to consultation requests that have national and international scope. I have put my hand up and have been involved in the steering group that pushed the agenda for New Zealand to create a hepatitis C action plan for 2030. The group includes leading medical doctors and hepatologists in the country. However, my involvement as a nurse meant that nursing has a voice in tackling national health issues like this. One of the actions we have undertaken is presenting to the Minister of Health. Indeed, this was exactly one of the workshops that we had during JNLI, simulated presentations to ministers of health, convincing, framing, and delivering the right message for policymakers and budget managers to understand. I feel that I have practically applied and translated what I've exactly learned from GNLI. I encourage nurse leaders and emerging nurse leaders to apply for GNLI. For nurses to influence policy, a balance of skills, experience, and training is required. Nursing has been recognized as a great and noble profession. But certainly, acknowledging nursing also means our voices are heard and consulted within a respective government's healthcare plans and agenda. When a failing healthcare system does not pay attention to its largest healthcare workforce, it will never be fixed. Therefore, nurses need to be proactive, and in order to achieve that, we need good leadership and policy training programs like GNLI. To finish off, I would like to quote Florence Nightingale's words, which says, "For us who nurse, our nursing is a thing which unless in it we're making progress every year, every month, every week, take my word for it, we are going back." What resonates with me, and it's this time and age, part of making progress is for us nurses being prepared and fully equipped in articulating our message to nursing and health and being actively involved in policy making. Thank you very much.
Thank you, Jed. Thank you very much, Jed Monter, a GNLI scholar from New Zealand. And now, without further ado, because, we got some time constraint, I would like to present now, if you would like to have some more information on the GNLI program, we have got all the information on our website, the International Council of Nurses website. And now I would like to introduce some scholars from the other program, the Leadership for Change program. And on behalf of Christine Qureshi, that I would like to acknowledge, but she couldn't be here. Actually, she was here the first days of this conference, but unfortunately, she had a minor accident. But she's having her presentation by Kathy Molsted, who is an LFC trainer from the Norwegian Nursing Organization. Please, Kathy.
Thank you. Thank you. So, we are moving from a global program to a national program. I have just a couple of minutes here. So, what has the program involves? First of all, it was established in 1995. One of the aims is to prepare nurses to implement organizational change, and we all know how difficult that is. The aim is to improve practice and achieve better health outcomes. The target are nurses in management roles. Now, we all know as well that going from management to leadership is difficult. You need different skills and you need a lot of courage. The program was revised in 2018. So how does it work? It's highly interactive. It's a lot like the other program in the fact that it's very personal. You have to change your behavior. Most of our participants had to do that. The content spans from a broad range of management and leadership concepts. It's difficult, but it's extremely exciting. The format is that you have 3 face-to-face workshops over 18 years, and it's team-based projects, so it's very exciting. And we had Norwegian nurses from all over the areas working in different settings, and it was extremely exciting to see these nurses working together and in networking. So, and Chris, the red here, note from Chris is that most of the learning occurs in the group work and collaboration on the change project. So here you see actually from the Norwegian group we had last year, 2 years ago. So just some quotes here from nurses that participated. Highly successful. It was a clear evidence to me that I have valuable knowledge levels. Another nurse, I emerged as a polished leader who can implement a change project with a group of other leaders. Another quote, it helped me in my individual development plan as well as the interaction and confidence with others. They really achieved a lot through this program. In recent countries, there's just a sample of some projects. One was from South Korea. It strengthened clinical nursing through leadership and management development. It improved international student progression and graduation in selected nursing schools. And in Lebanon, 2 projects developed and implemented a policy for appropriate use of smartphones for 7 Beirut hospitals. So it's policy changing. Another project from Lebanon was implemented of a communication system, probably an EHR system, in 7 hospitals to improve reporting of clinical information. So these are exciting things, and we experienced that some of the projects were national, but they became international. So how can you do this? First of all, look at ICN's website. Go to where they have the different programs, what we do, programs, and look for information on LFC. There is a leaflet available somewhere in the room, at least maybe at the ICN booth, I'm not sure. Contact LFC and ask them about the program. And the woman in the middle here is Chris Qureshi, should have said. That is at home in Hawaii right now. Thank you.
Thank you so much, Kathy. And please, I would like to introduce you the first experience of the LFC program that was offered in over 70 countries in the world. And I have the honor to have the president of the Taiwanese Nursing Association, Shu An Wang. Please.
Thank you, Alexandra. Taiwan Nurses Association has hosted 3 highly successful LFC programs since 2015. It has also sponsored colleagues from other countries to participate in the Taiwan LFC, including Myanmar, Indonesia, and Vietnam. All programs rated highly by the participants. For the 2 programs, there are 42 graduates and 22 participants in progress, including 16 from Taiwan, 2 from Myanmar, 2 from Indonesia, and 2 from Vietnam. The Change Project have had a remarkable level of sustainability. We have 12 team projects. I would like to share 2 successful team projects. The first one is from Taiwan. It developed an electronic platform to support evidence-based nursing practice and shared EBHC knowledge nationwide and applied in the clinical practice. The second team project is from Indonesia. It developed standards and core competencies for 6 clinical nursing specialties in Indonesia and will be implemented in a general hospital. The LSC programs has transformed the participant. I would like to share 3 stories. First, Ms. Kim from Myanmar. Quote, "The LFC program is very effective and needed for nurses. We gained a lot of knowledge and experience about leadership and management skills with support nursing personnel and professional resilient." Dr. Dai from Taiwan, quote, "LFC helped me boost my self-confidence, increase courage, grab the chance, and make changes." Dr. Yati from Indonesia, quote, "I learned much more about how to be a good leader and have more confidence in leading a research project." A cadre of 13 senior expert LFC trainers from Taiwan Nurses Association have been trained. All will have gone through the newly revised LFC program 3 times at the end of the current program. These Taiwan Nurses Association trainers are available to provide regional training in Asia. Thank you very much.
Thank you very much indeed. And now I would like to introduce the Chinese Nursing Association and Professor Weilin Zhang. But before beginning your presentation, Professor, I would like to acknowledge the generosity of Johnson & Johnson to have supported the program in China. Thank you.
Thank you. Good afternoon, ladies and gentlemen. I'm Zhang Huilin. On behalf of Chinese Nursing Association, I will report the progress in LFC program in mainland China. CNA has hosted 2 highly successful LFC programs during 2018. The LFC program has been rated highly by CNA participants. Most recent program rated 4.8 on a scale of 1 to 5, with 5 highest. The change projects have had a remarkable level of sustainability. One example, a project to reduce workplace injuries among nurses in China. This project was accomplished by Hunan, Zhejiang, and Jiangsu province. Of 699 nurses served, 76.38% reported they sustained at least 1 injury during the past year. Based on the survey, a standardized process for the prevention of needle stick injuries was constructed and is being implemented in Hunan Hospital, China. This project includes not only needle stick injuries prevention, but also back pain prevention, involence prevention, and so forth. Another example, a project to improve the professional identity and retention intentions of nurses during orientation training. This project carried out in Hubei province. After the intervention, the retention intention of newly hired nurses increased, and the turnover rate has reduced within 1 year. The implementation of the project, the team members has improved leadership, execution, and cohesion. LFC program impact on the individual. The lady is first picture is Qin Yuelan. She's the vice president of Hunan Provincial People Hospital. She said, leadership changes the environment in which nurses practice. The second picture is Li Weihua. She's a vice director of nursing department from Guangdong province. She said, leadership is the soul of a team. CNA now has many ICN LFC trainers. 23 senior expert LFC trainers from CNA have been trained. All have gone through the newly revised LFC program. Mainland China has over 4 million registered nurses. These CNA trainers can train nurses across China. That's all. Thank you very much.
Thank you very much, Professor. And we really hope that many more countries will consider hosting an LFC program in their own country. And now we will ask Dr. Karen Bjoro from the Norwegian Nursing Organization and member of the International Council of Nurses Board to make some concluding remarks about these two ICN programs, because she is a leader who has participated to these two programs. Please, 2-3 minutes. Thank you.
Thank you. Thank you. I timed this at 3 minutes and 59 seconds, so here we go. Good morning, or good afternoon. My name is Karen Bjoro, Vice President of the Norwegian Nurses Organization and ICN Board member, and also a GNLI alumni from 2016, which was Jane Salvage's maiden voyage into this program. Thanks for the opportunity to reflect on the synergies between the two leadership programs that ICN offers, the GNLI and the LFC, from the perspective of the Norwegian Nurses Organization. Our journey with ICN leadership programs started with the GNLI program in 2015, when 2 NNO members attended the program. One of the attendees was our Department Director of Nursing and Health Policy Department. And her personal goal was to set up the Leadership for Change program when she got back to Norway. She succeeded in getting approval from the Board of Directors of the NNO to run the program, and in 2016, the first LFC program in Norway was launched with 34 nurse leaders taking part. So far, we have run one LFC program, and we have had 5 GNLI graduates over a 5-year period, including myself and our president, Ellie Gunhild B. We are planning to run our second LFC program, and 2 members of our staff, including Kati Mørstad and Øyvind Nordbø out in the audience, have participated at the first, they participated in our first LFC program, and they also participated in the accreditation program here in Singapore, which is a train-the-trainer program to accredit them to be able to conduct the LFC program independently. So, we will also have 2 new GNLI participants this fall in September, a total of 7. So, in Norway, we have about 6,000 nurses in leadership positions in healthcare services. Most of them are among our 115,000 members. About 90% of leaders at the front line in Norway are nurses, where they are critically important for their staff, patients, and family at a local level. But to tackle the healthcare development and challenges higher up in the clinical setting, and also at the national level, and indeed at the international level, it is important to increase the number of nurses at top-level leadership positions in our country. Our strategy is to motivate and challenge nurse leaders to plan an even more active role in setting the agenda and contribute to development of health care for better health outcomes. And to do this, we are committed to develop leadership capacity through the 2 ICN programs. The focus of both programs is to develop political skill, visionary leadership and ability to think strategically, development of confidence and self-efficacy, influence and negotiation skills, as well as development of networks, partnerships, and alliances that they didn't have prior to attending the program. All these skills, of course, are really necessary for policy impact. By committing to both ICN leadership programs, we are developing leadership capacity skills aiming at 2 levels. GNLI aims at the national and global level, and LFC at the local and national level. So the 2 programs seem to converge at the national level. Participating in this session has raised my awareness of the need to capitalize on the synergies between the 2 programs. And now that we have developed capacity, we need to take out the benefits to a greater extent. And we've been discussing a few of the ways that we might be able to do this. For example, I could attend the LFC program. You know, sometimes they go from the LFC up to GNLI, but we can also go from GNLI to LFC. So this is a good way to create synergies, I think. And then maybe I would be able to be a trainer for other nurses at the local level. So this is one potential way that we could do that. And I see Eyvind's nodding out there, so that makes me very happy. So anyway, I think that's what I have to say here today. So welcome on board to the ICN leadership programs. We really need to develop our capacity to lead nurses forward. So thank you very much.
Thank you very much. What a wonderful summary and wonderful and also potentialities for these 2 programs. And before ending the session, I would like to acknowledge and to thank all the nursing national association who are supporting these 2 programs. And thank you very much for everything. Thank you. Thank you. Well done, Jane. Yeah, thank you.